Welcome to Dr. Balga's podcast for the Curious Doc. Today is February 11, 2026. This video is a Lancet article published yesterday online, 10th February 2026, titled New Drug Therapies for Hypertension. The first class discussed today is RNA-based therapies. What is the therapeutic target for these therapies? They inhibit hepatic angiotensinogen synthesis to suppress renin-angiotensin system upstream. Which agents lead this class clinically? Zilebesiran is the first in-class small interfering RNA targeting angiotensinogen. How is zilebesiran administered? It's a subcutaneous injection with sustained efficacy for approximately 6 months. What blood pressure reduction is being observed in trials? Phase 2 trials showed a double digit, that is about 15 millimeter reduction in 24-hour ambulatory systolic blood pressure versus placebo. What is the principal clinical advantage? Durable blood pressure lowering with improved adherence compared to daily oral therapy. What safety issues accompany these RNA-based therapies? Risk mirror renin-angiotensin system blockade, including hyperkalemia and transient decline in eGFR. Why is reversibility a concern? The long duration of action limits rapid reversal during acute hypotension or volume depletion. Are these agents suitable in pregnancy? No, they are contraindicated due to the role of angiotensinogen in placental perfusion. Do RNA therapies replace ACE inhibitors or ARBs? They are intended as add-on or alternative strategies rather than universal replacements. Which patients may benefit the most? Those with resistant hypertension, poor adherence, or high cardiovascular or renal risk. The next group of drugs discussed is aldosterone synthase inhibitors or ASIs. What do these agents block? They inhibit CYP11B2 to reduce aldosterone production at its source. Which agents are most advanced? Baxdrostat and lorundrostat have completed large phase 2 and phase 3 trials. What blood pressure effects are seen with these agents? Consistent placebo-controlled systolic blood pressure reductions of approximately 8 to 12 millimeters of mercury. What endocrine concern drove drug design? Avoiding cortisol suppression due to CYP11 beta-1 cross inhibition. Do these agents affect aldosterone escape? Yes, they directly prevent aldosterone escape seen with ACE inhibitors or ARBs. What are the adverse effects of these aldosterone synthase inhibitors? Hyperkalemia, hyponatremia, and mild reversible declines in eGFR. Is adrenal insufficiency a concern? No. Clinically meaningful adrenal insufficiency has been reported in trials to date. Which populations require caution? Patients with chronic kidney disease or elevated baseline potassium. Can aldosterone synthase inhibitors be combined with other therapies? Yes, particularly with SGLT2 inhibitors to mitigate renal and potassium risks. What unmet need do these agents address? Resistant hypertension driven by aldosterone dysregulation. How do non-steroidal mineralocorticoid receptor antagonists differ from spironolactone? They provide greater receptor selectivity with fewer sex hormone-related adverse effects. Which non-steroidal MRAs are highlighted? Finerenone and esaxerenone. What is the blood pressure lowering magnitude of finerenone? Modest reductions of approximately 2 to 5 millimeters of mercury systolic blood pressure. Where is esaxerenone currently approved? Primarily in Japan. Are non-steroidal MRAs approved for hypertension? They are mainly approved for CKD or heart failure rather than isolated hypertension. What is the major safety concern with MRAs? Hyperkalemia, particularly in CKD or diabetes. How do non-steroidal MRAs compared to spironolactone. They're better tolerated but generally less potent for blood pressure reduction. Can MRAs be combined with SGLT2 inhibitors? Yes. Combination therapy may reduce albuminuria and potassium risk. What clinical role do mineralocorticoid receptor antagonists serve? Targeting aldosterone-mediated cardiovascular and renal injury. Which patients benefit the most? Those with CKD, diabetes, heart failure, or aldosterone excess. The next group of drugs are endothelin receptor antagonists. What's the role of endothelin 1 in hypertension? It's a potent vasoconstrictor upregulated in resistant hypertension and CKD. What endothelin receptor antagonist is approved for hypertension? Aprocitentan is approved in the US, Europe, and the UK. In which patients is aprocitentan indicated? Patients with hypertension uncontrolled on at least 3 drugs. What blood pressure reduction is observed with aprocitentan? Clinically meaningful and sustained systolic blood pressure reductions in phase 3 trials. Why were earlier endothelin receptor antagonists abandoned? Due to liver toxicity and excessive fluid retention. What adverse effects limit the use of endothelin receptor antagonists? Fluid retention, peripheral edema, and heart failure risk. Is pregnancy a contraindication? Yes. Endothelin receptor antagonists are contraindicated due to teratogenicity. When should endothelin receptor antagonists be considered? When mineraloreceptor antagonists are ineffective or contraindicated. Do endothelin receptor antagonists improve renal outcomes? They may slow CKD progression but require careful volume monitoring. What distinguishes aprocitentan from earlier endothelin receptor antagonists? Improved tolerability with sustained blood pressure control. The next group of drugs are RNAs. What's the role for natriuretic peptide enhancement? To promote vasodilatation, natriuresis, and blood pressure reduction. Which approved drug indirectly enhances this system? Sacubitril valsartan via neprilysin inhibition. Is sacubitril valsartan widely approved for hypertension? It's approved for hypertension only in select countries. What blood pressure effect is seen with neprilysin inhibition? Modest, but clinically relevant blood pressure lowering when added to ARB therapy. What limits broader adoption? Cost, angioedema risk, and limited hypertension-specific approvals. Are natriuretic peptide agonists in development? Yes, several peptide-based agents are under investigation. What safety issues apply to this class? Hypotension and angioedema, especially in combination with ACE inhibitors. Do these therapies replace standard antihypertensives? No, they serve as adjunctive strategies. Which patients may benefit the most? Those with resistant hypertension or concomitant heart failure. What's their future role? Potential niche use in multimorbidity driven hypertension. This Lancet review article is outstanding. Read the original article to get more details. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.